Hello, everyone. Welcome to today's Health Affairs Professional Development session, and thank you for joining. We're delighted to be talking about two essays in the October issue of Health Affairs in the Narrative Matter section that touch on the topic of racism. And we will talk a little bit about the Narrative Matter section and then hear from the authors. So today, questions may be submitted through the Q&A tab at the bottom of the screen. No need to wait until the Q&A portion to type in your questions, so feel free to enter them in the chat at any time during the presentation, and we will get to them all at the end. Events like this are typically exclusive to Health Affairs Insider members, and that's a community offering exclusive access to content beyond a Health Affairs subscription. If you're attending the event today and are not yet an insider, we encourage you to join our membership community today. You can use the code HAInsider10 for $10 off an insider or unlimited membership at healthaffairs.org/subscribe. So go ahead and start my slides here. So the Narrative Matters section of Health Affairs features personal stories about experiences with the healthcare system and the people in it, using the power of literary nonfiction to highlight an important public policy issue. Next slide. Just by way of background, the section was first published in the July/August 1999 issue of Health Affairs. We consider these policy narratives in that they have a compelling healthcare story with a clear tie to policy. We feel that narratives add a human context to evidence-based healthcare decision-making, putting a face to sometimes faceless debates. We welcome essays from anyone with a healthcare or health system story. It could be doctors, nurses, patients, community health workers, caregivers, children's students, and more. Next slide. There are four key elements to a successful Narrative Matters essay. One is a compelling story where we meet fully fleshed out human beings and find out what happens to them. Next is a complete story that incorporates a narrative arc with a beginning, middle, and end. Third is an insider's view. So we want to know something more about something we may not know about and something the writer is intimately familiar with. And finally, we are looking for a big picture message. And that for us is the policy tie-in. So showing that this is not just a story about an unfortunate but isolated incident, but a broader issue that affects many. Next slide. The essays are peer review. They are typically unsolicited. They come in around 2,000 to 3,000 words. And we also welcome abstracts for Narrative Matters ideas during our open requests for abstracts. So email narrativematters@healthaffairs.org if you would like any more information about this. Next slide. So first, I would like to introduce Miranda C. Ward. She is an assistant professor and director of equity in the Department of Clinical Research and Leadership in the George Washington University School of Medicine and Health Sciences. In this role, she designs, evaluates, and teaches health equity curriculum for student and faculty learners. She's a community educator, curriculum developer, and youth builder. She has strong commitments to service learning, equity, community legacy, youth development, and honoring youth voice. She wrote the essay, Changing How the Healthcare Workforce Sees Patients Like Me, in this month's issue. In this essay, she describes a police encounter at her dental office and how it reveals how racism can operate on many levels. And with that, I will turn it over to Dr. Ward to tell her story.
Hello, everyone. So, thank you so much to Health Affairs for this super important, timely, necessary, important issue on structural racism and the opportunity to really kind of highlight an unfortunate reality for many of us in just enduring racism in all its forms in a range of settings, but most unfortunate when we actually encounter it in healthcare settings. So, as was said, my name is Miranda Ward, and I am a faculty member at the George Washington University. And one of the things that, I often highlight to my students, because I teach health equity courses to a range of health profession students is how, pervasive racism is. And, even though, yes, I'm talking about racism in the classroom with undergraduate students, I'm talking to faculty members about how to talk about race and racism in their health professions classrooms. When I log off Zoom, or when I, finish the training, or I'm, basically the class comes to a close, the conversations and my experiences with racism don't end, right? I'm literally always either observing or firsthand experiencing racism. And so this is why I knew it was really important for me to take some time to really kind of tell my story, just because writing has always been very cathartic for me to really kind of process what happens to me in a range of spaces. So one day, interestingly enough, it's just so ironic, the day that I was actually being awarded with a Justice, Equity, Diversity, Inclusion, Community Engagement Award from Transatlantic Mid-Atlantic. They were basically wanted to recognize me for the structural racism curriculum that I'm actually doing with a group of medical students at GW, to really understand, medical racism, scientific racism, and race-based medicine. So the day that I was actually to receive this award was the actual day that I had the police called on me while I went into my dental office to basically be seen for a crown. And so, I literally just walked in. And again, I'm not a new patient. I have been going to this particular practice for a while. I want to say almost 7 years. And basically, this was, I want to say, like a year ago. So, I mean, obviously COVID's is endemic now, but people were still encouraged to wear masks in healthcare settings. And so I had my mask on. And even though I had my mask on, just the reason why I'm bringing this context is I had my mask on, but they still knew it was me, right? There's something about being like a long-term patient and then just caring about, like their kind of client base. So they greeted me by name, knew who I was, even though I had my mask on, signed in, checked in, had a seat and all the things. And, was brought in promptly to the back to be seated, where I actually did take off my mask. And then, was just kind of joking along with the attendant from the front desk, because I was there like not too long ago. And it was just how I knew that I needed to kind of get a new crown. And my dental practice, they give you these sunglasses that say the name of the, dental practice, and I like to recycle. So I was like, you know what? I brought my glasses from last time. Y'all got to give me a new pair. So, we were joking and everything. So I'm thinking, you know what? I'm about to see my dentist any moment now. I'm looking on, my phone, scrolling through my social media feed. And then someone that I don't know came in and introduced themselves as a treatment coordinator. And I looked up, and I was talking with them, and they mentioned how they just wanted to make clear that I needed to pay 80% of the crown, right? It was expected that 80% of the procedure will be paid, in advance before they can get started. So I must admit that this definitely was news to me. Like I said, here I am, a long-term patient. I had gone back and forth with the, the kind of scheduling office, the front desk office about, my appointment for that day. And I was prepared to pay a different amount, not 80%, because, my insurance was supposed to cover a portion, and then I would cover a portion, and then we would, work out the rest, which is what I've done up until this point for the last 7 years. So again, I was, definitely taken aback that, I was being told that I'm not going to be seen because 80% of this procedure hadn't been paid up front. So I was like, well, y'all knew about this what seems to be like a new policy. Like, why would you wait until I'm seated for the procedure to tell me that ultimately I'm not getting this, the crown today? Because I'm thinking I was going to get a crown. She's like, no, you're not even scheduled for the crown. You're scheduled for a crown, buildup, which is like, the step right before the crown. So again, there was just a lot of miscommunication. And so I was like, what would be really helpful for me is if I just go ahead and talk to my doctor. And I was told, no, you're not talking to the doctor. If you have questions, you need to talk with me. And I was just like, well, I know that I can talk to the doctor. I had a scheduled appointment, so I know that, he has time. So I'm going to go ahead and just wait for him. And I was told, no, collect your things and, leave right now. And if you don't, I'm going to call the police. What? what is the threat of police for? Like, like in this encounter up until this point, there's no reason that the police need to be called because I'm asking to talk to my doctor about a procedure that I had a appointment for. And again, I'm a long-term patient, so like I don't even know like what's happening at this point. So she leaves. I'm standing in the doorway, like, what is happening? And then I see her talking to the doctor, and basically, she comes back like, well, he can go ahead and answer clinical medical questions, but if you got, any kind of financial questions, you need to go ahead and leave. And I told you, I don't appreciate you being disrespectful to me. And I'm like, how am I being disrespectful? And the thing is, see, I actually, when I'm having a conversation, I do use my hands. I gesture, and that's just my personality. Everybody has different ways to communicate. And so it was clear that, she received that as threatening, the fact that I gesture with my hands. And so ultimately, she, basically wanted to assert her authority and made it clear that I'm gonna go ahead and end this conversation now. Like, you don't get to talk to the doctor. And if you're not gonna pay, you need to swiftly, exit the premises. And I refused to exit the premises and went and had a seat. And I was like, I will be talking to my doctor because I knew my rights. And then she proceeded to call the police. And she put it on speakerphone. And so I hear her, explaining to the police what I have on, right? Everything like, oh, she got on jeans, she got on pink Nikes, she got on, she explaining all the things. And I'm like, my heart is like racing. Like, I could not believe she's sitting here explaining, what I look like so they can come and, like, what are they going to do? They're going to come arrest me for what? What was the crime? I'm just like, I can't even believe this is happening. And so then the medical assistant comes in, says, you know what, actually, the doctor will see you. I'll get escorted to the back. The doctor's sitting back there like, you know what, like, come on in, like, what's going on? Like, I'm trying to figure out like what's happening. I see through his big bay windows, because his windows literally are like facing the street, so you can see the police car pull up. And so I'm trying to talk to him, but I feel distracted because I know the police are for me. So I'm like, oh my God, here they come. Like, and you asking me like what's happening. So I'm just like, a lot's going through my mind. So I'm just like, okay, I have a relationship with him. So I'm trying to like explain all the things and how I literally feel like, I don't appreciate how I've been treated up until this point, and I appreciate you asking me to come talk to you. And I'm being told that I can't talk to you. The police come in, he waves them away like that's unnecessary. They go and leave, and then I'm explaining to him like, I just really don't feel safe and comfortable. Like the fact that the police are just called on me, and there's just no explanation for why that's the case, why that would even be necessary, right? Just like definitely a waste of taxpayers' money. And, he was just like, you know what, let me apologize for that. I will let you know that this is a new policy that I put in place because oftentimes patients come in and they get procedures done. They don't have the money. We basically do the procedure and now we're out of, money. We're out, basically it's from a business perspective, we're losing money on doing, basically doing procedures that patients can't pay for. And I was like, I completely understand all of that. And also and like two things can be true at once, right? I can understand from your business perspective why you have this policy. And I also don't need for, the policy to be, I guess, communicated to me in that way, right? And then also, again, like everything that kind of came with the communication of that policy was unnecessary. And like I said, I'm a long-term patient, and I've never reneged or not defaulted on any of my bills. And right, so I'm just kind of like, I just felt like in this particular case, none of this made sense. So he was like, you know what? It's, a lot's gone on. I would like you to come back, but since all this transpired today, let's just go ahead and have you leave here and you can come back and we can schedule it. I went home and immediately wrote out my thoughts on everything that happened. Because like I said, I feel writing is a really good way for me to kind of process what I'm feeling in real time. And really, I wanted to also let him know how I felt about this whole encounter. So I did send him an email and shared how, you know what, I will return and talk with you about the procedure. And in the meantime, I need you to know that like the threat of police is anti-Black, and it's a act of violence in and of itself. Right. And so I like named it as racist, and like the policy that they put in practice has racialized implications, and I put all of that in writing. And he immediately called me and was like, you know what, please come and see me. I will waive this policy. You're right. This this is not right. You've been a long-term patient of mine. I'm going to go ahead and start the procedure. And, I can't do anything about, the treatment coordinator, but, that was wrong of them. And I'll have a whole conversation with them. But then later he did contact me and say, you know what, it's on second thought, I decided the treatment coordinator, doesn't belong in my practice. Like, that's not what I believe in. And like the way they kind of handled that is, was unnecessary. So in my essay, one of the things I write about is, there's a couple of things for those of you who have read it. Thank you. I look forward to your thoughts and your responses. But for those of you who have not read it, there's a couple of plot twists, and I'll say in the writing of my essay. One of them is the fact that, as you're reading about the treatment coordinator, I never explain who the treatment coordinator, I just say the treatment coordinator. And later I reveal that, oh, actually the treatment coordinator is a Black woman, right? So up until this point, you may have just assumed that it was a white, person, but it's kind of like, okay, I really kind of take some time to explain how, white supremacy operates, in the absence of white people. Absolutely. Right. And give some examples of what that looks like and how racism shows up in so many forms and gets internalized. And then the other kind of twist is that this is not squarely the responsibility solely on the treatment coordinator. The dentist actually had a role in enacting and maintaining racism as well. So I kind of talk about both of those, and then I move into the policy implications, like the actual policy itself. When policies produce racialized outcomes, then that means that there's an issue with the policy, right? When so then we really need to take up payment policies and what that means for patients, especially patients of, we just think more broadly about what this means for patients of color. And then when we already know, but just thinking about dental coverage, we often talk about medical coverage and how, communities of color have been disproportionately impacted by not having access financially or even being underinsured. And we often don't even talk about what that means for dental coverage, because we're even less insured when it comes to dental coverage, right? And so, so basically I pull in some of the implications of that in the piece. So I welcome any questions that you have, more specifically about, how the story unfolds further, but I want to kind of just take time to sit in here and, allow for any questions that come up.
Thank you so much for sharing your story. It was definitely a pleasure to work with you on it. And I know writing about that experience was, I'm sure, challenging. And so I really appreciate you sharing your story and look forward to talking about it more during the Q&A. So next I will introduce Miss Alexis Grant Panting. She's a doctoral student in sociology at Texas Women's University in Denton, Texas. She's a community engaged scholar, passionate about helping young people who come from marginal backgrounds like her. Her work draws on her experiences as a Black woman, a first-generation student, and a mother. Her research interests center on rural communities, education, and public sociology, focusing on the experiences of people of color, mothers in academia, and inequality. She wrote the essay, A Black Woman's Pandemic Birth Experience, in this month's issue. In this essay, she tells the story of the birth of her second child and reflects on why Black women like her have come to fear their birth experiences. So now I'll turn it over to you, Alexis, to tell your story.
Hi, thank you. Thank you all for putting this together and inviting us to talk. And I will give a warning. So in the background of my talk are pictures, and these pictures kind of encompass my total pregnancy experience. There are at least one or two things in there that may be graphic. So if that is sensitive to you, please feel free to turn away. And it'll kind of be on a loop, just playing the whole time. So unfortunately, I can't give a warning as to when it's going to pop up, but I do want to make that known. So this essay, this narrative that I wrote, as Jessica mentioned, was really about my second pregnancy with my youngest child, who is my little COVID baby, as we like to say. But I really was not expecting her, but there was a lot happening at the time during my pregnancy and ultimately labor. One, of course, was the pandemic, which impacted all of us in numerous different ways. But of course, another aspect of that was living in Texas, living in a predominantly rural area. Um, you'll see images of where I actually live, and the closest medical facilities are at least 2 or 3 towns over. The closest large hospitals with maternity wards are about 45 to 50 miles away, just to give you some context. And then on top of that, during this pregnancy, there were other things that happened contextually, like Texas had an insane snowstorm, which was very historic. And at one point, I was without electricity and running water and heat and negative-degree temperatures for 2 to 3 weeks. So there was a lot that kind of happened, environmentally speaking and community-based speaking, while this pregnancy happened, that just kind of made the traumatic experience feel even more pronounced. So I found out I was pregnant with my now Jada, who's now 2, in December of 2022. And at the same time, I was bearing my grandmother-in-law, who I was very, very close with, spent a lot of time with her, had many conversations. And in my essay, you'll see a glimpse of some of those conversations. But prior to getting pregnant, she had asked me many times, when are you having another one? When are you having another one? And I was like, I don't know, because I don't want to have a baby in Texas, because my oldest was born in California in a very different setting, a very natural, holistic setting. And I had read a lot about giving birth in Texas. I read a lot about the experiences of Black women, because I am a mom and I'm a part of a lot of different moms groups across the country. And so it was a fear that was instilled in me, and seeing the numbers definitely made that an even heightened fear for me. And so when I found out I was pregnant, I really was terrified. Like, one, COVID was happening, and I have to go into the hospital and, essentially say final goodbyes to my grandmother-in-law, while at the same time knowing that I have to be extra cautious because I am pregnant. And then also knowing that I had to go through a lot of those medical office treatment things alone, because no one could go with me. And during my first pregnancy, that was not the case. My husband was by my side every step of the way, every single appointment, every single sonogram. And this one was very much lonely. Like, I remember the first time I went to the doctor's office and walking in, like, mask on my face, lobby was like completely deserted. No one was in there. And you're talking to a glass and they're like, name, and, no company with you. So I just remember feeling really lonely. And that kind of stuck with me throughout, in the sense of when I would go and be seen by my doctor. So there's a couple things that happened that were big things that really impacted ultimately my labor and birth. I spent a lot of time researching for Black midwives and doulas. And in the DFW area, you would assume that with such a large Black population, they would have a lot. But at the time, they had 2 midwives, and they were booked, so I could not get in with them. And I was in the process of switching from my doctor to a midwife when I did find one. But unfortunately, I got diagnosed with a pulmonary embolism and blood clot on my lung when I was about 11 weeks pregnant. And that first incident in the hospital after that was really traumatic. It was at the small regional hospital, miles away from my home. My husband couldn't be there. I remember walking in by myself and just saying, I've been told I might have a blood clot. I need to go see someone, and it's COVID, right? So they rushed me in, they checked me. And I just remember the doctor who was on call that night, the ER doctor, was very, I don't know if it was aloof or disconnected, but he just seemed like he just didn't really care about me. It seemed like he didn't listen to what I said. Like, multiple times he referred to my husband as my boyfriend. And for me, that was very frustrating, because I know how people treat Black unwed mothers, right? Like, I research this all the time. And so at one point I was like, hey, he is my husband. Like I told you, please stop referring to him as my boyfriend. You've talked to him 4 times tonight. At one point he told me that, yes, I, have a blood clot, after they, solidified it, and told me that I need to get a CAT scan. And I was like, what is this going to do to the baby? And he was like, well, it could, potentially kill or hurt this baby. We don't know. And I was like, can you get a second opinion? And he was like, well, you need to do it. Your life is more important than the baby's. And I'm like, well, I need another opinion. And I just remember him seeming like he was frustrated that I asked for that, and walked out. And I was like bawling and crying and on the phone with my midwife and with my husband, like, what do I do? And at one point, a nurse walked in because she had overheard the conversation. And she was like, she looked me in the eye. She was like, listen, you have to be here for this baby. You have to be strong for this baby. Like, you know what you need to do. Ask for it. If you need support, people are here to support you. And I was like, we'll see, but okay. And so I called him back in and I told him, get a second opinion. And he finally did, and ended up actually calling what would be my future high risk doctor, who turned out to be a Black woman. And they told him, yes, I could get a CT if he did extra precautions. So I went in for that, which of course he didn't document that I was actually pregnant. So as I'm getting wheeled into radiology, they had no idea. They only found out because I asked to go to the restroom. And I said, this baby's pushing on my bladder. And the radiologist was like, what baby? And I was like, I'm pregnant. And he was like, that's not in your notes. And he was like, you go to the restroom. I'm going to go handle this. And so he went and handled it while I went to the restroom. But he was like, do you know the damage that could have happened had I pulled you into radiology and didn't know you were pregnant? I wouldn't have put on the right protection, things like that. And I was like, well, luckily for, I had somebody in there who knew the importance of that. But that was just one thing. I spent the rest of my pregnancy having to be treated for high risk. I lost my midwife at that point because she could no longer treat me. And then I was seeing my doctor, who at that point, looking back on it, I wish I had switched doctors, but my mindset, I was like, I got to get shots in my stomach twice a day. I have to think about my other child, like, snowstorms. Like, I just couldn't even process thinking about switching doctors. Even though my husband was like, I don't really like this lady. I don't know how I feel about this lady. My brain was like, I can't even get to that point because I'm trying to like survive every day. But as we got closer to labor, there was just some flags that I should have paid attention to. And looking back and reflecting on it, if I ever go through labor in Texas again or pregnancy in Texas again, I know what I would do differently. But there was things she said, like I told her I wanted to have a natural birth. I told her I wanted to go as long as I could with the baby. And she was insisting on, early delivery, C-section. And I was like, I don't want those things. I want these things. And she was like, well, you can't have them. And I'm like, well, my high risk doctor is telling me I can. You're telling me I can't. Can you two talk and figure this out? And then she would say things like, you go ask her. And if she says yes, then we'll do it. Like, me delivering at 38 weeks instead of at 36 weeks. And I was insistent on that because I said, I want the baby's lungs to be fully developed, things like this. So, I spent a lot of time educating myself and, trying to put myself surrounded by a birth team that I felt comfortable with. But at the same time, it was really challenging to find that birth team in Texas because COVID was happening, because of restrictions, because of not being able to move about, and because Texas' healthcare system is set up in a way where it's very individualized. It's not, there's no like cohesiveness to it. So there's no one-stop shop to go and get help. You got to figure it out on your own and weed through it. And so I ended up having a birth team with a Black doula, a Black high-risk doctor who was not there during my labor, and then my primary OB, who was in and out throughout my labor, but was not very helpful. If you read the article, you'll see some of those components. But, after 56 hours of labor, which was a lot of pushing and pushback of not wanting a C-section, of asking to be able to walk and being told no because it's COVID, and walking in the hallway is different versus walking in my room when we were breathing the same air. Didn't understand. Of being told I couldn't, sit on the toilet to relieve pressure from my belly. The baby finally came out vaginally, which is what I wanted. But I remember when I pushed her out and I was holding her on my chest, and I talked about this on the essay, I was like, oh, the baby's finally here, I can relax. And then I remember, birthing the placenta and everything. And the umbilical cord. And I remember everyone in the room just taking a deep breath and go, like shock. And I was like, what the hell happened? And then they were like, oh, there's a knot in the cord, like a true knot. And I didn't even know what that meant at the time. I looked it up later and realized that it was something that's very rare and actually could be detrimental to the baby. But in that process of looking back on the experience, just thinking about this actual knot that was in the core versus, what we go through structurally as people of color within the healthcare system, it was something that I thought was really important to kind of work through and untangle a little bit, particularly in thinking about what was the connections between being Black, between COVID, between birthing in Texas, right? And one of the things that really stood out to me was the lack of respect of autonomy. I felt like a lot of the doctors did not value the fact that I could make choices for my healthcare, right? And for my birth. Like, women have been birthing since we've existed, 300,000 years. I think I know a little bit about my body. This is not my first birth. I think I know what I'm doing. But they didn't trust that. And they kept insisting that I do it their way in their time instead of giving me time to process and make decisions that I felt was best for me. And I think that's really a structural issue that we need to really look at and think about how that impacts particularly Black and brown women within the healthcare system. I'm going to end there because I do want to have some time for Q&A as well. And if the slideshow stops, or you can stop it, whatever best fits. But thank you all.
Thank you so much, Alexis, and thanks to you both for sharing your stories. So we'll open it now up for discussion. As a reminder, questions can be submitted through the Q&A tab at the bottom of the screen. So I'll start with a question from the audience for Dr. Ward. Dr. Ward, you said something like, if a policy has racialized outcomes, we need to examine or change that policy. Could you talk more about that?
Absolutely. So thank you for the question. So basically this is about this. So me making that point is me raising, what is this an issue of? Is this people issues? Is this a policy issue? And so I feel like oftentimes, the unit of analysis actually should be at the policy, but we focus on what the people are doing or saying or not doing, and we make them people issues. And so I feel like we need to shift the unit of analysis and really look at, okay, what policies do we have in place that are producing the, inequitable outcomes that we see amongst patients, right? So for example, I'm not sure if you're familiar with there's a resource by an organization called Race Forward called the Racial Equity Impact Assessment. The DC City Council uses this. We've been using it, in some capacities at GW in the School of Medicine and Health Sciences in different departments. But ultimately, it literally is a set of questions that says, you know what, we want to have equity. And so we have to be intentional in whenever we make decisions, right? Whether that decision is a policy, whether that is, allocating resources, putting together the budget, we need to be very intentional in codifying our values for equity in the first place. So the types of questions that you ask are, okay, what racial ethnic groups are actually going to be most affected by this fill in the blank policy, practice, decision, funding, or restricted funding or closing of the program or whatever it is, right? And then that means that you also have to move beyond intent and look at impact. So it's no longer, what we intended to do, like in the case of the dental practice, what we intended to do is prevent, patients from getting full procedures and, and basically defaulting on their payment plans. That was the intention, but what's the impact? The impact is that you have unintended consequences where, depending on the nature, so like some obviously dental procedures are timely. Can you, if you're on a payment plan to have 80% paid, you have to, there's a time factor where you're not getting that procedure done until you have, this procedure paid. So what does that mean? What's the implications of not having a necessary timely procedure done because you're waiting for either insurance to cover it or you out of pocket have to put money towards it to like actually pay for it? one, and then just the implication of what that means and how it's communicated to you and how you're treated when they find out that you need to be on a payment plan, you can't pay for it up front, you don't have the type of insurance that's just going to cover it, right? And that differential treatment, that's unfair, and that literally, like I said, even though like that's the policy, but people actually have to implement the policy, and that becomes a practice issue, right? How do you communicate this policy? What does that mean to, not actually offer basically treatment plans to people who need it in the time that they need it because they can't pay, right? So ultimately thinking about how is this affecting patients of color? How are they negatively impacted by this? What are the adverse impacts that either could be prevented, that could be minimized if we really kind of thought at the outset about the implications of this policy? So that's what I meant by these being policy issues, not people issues.
Great. And someone asked for the name of the resource you mentioned. Again, was it the Race Forward Racial Equity Impact Assessment?
It is. Yep.
Okay, great. I have a question for both of you from the audience. If you are faced with the same issues again, how would you handle it differently? And start with Ms. Grant Panting.
Well, it's hard because I feel like I'm privileged in a way where I have some knowledge and education about like birthing and birthing outcomes, where I don't think most or average people do who aren't doing this work, right, or in this field, or first time moms. So I think that next time, earlier on, I would definitely switch providers up front. I did do a lot of research on where I wanted to birth at, and I thought where I picked was a good hospital. But now I know that there is an app called the Earth app that Black women go on, and they, give critiques on different places of birth. And I would use that instead of going through my health insurance company to try to find something. And I would kind of backward match one. Two, I would listen to my instincts. I at one point told the doctor when I was in labor that I was going to leave. I was like, I don't care if I am in active labor, I'm out because you're not listening to me. And I would actually like follow through, because it could have been very differently. Like, she told me at one point that if I kept doing I was doing, she was going to have to give me a hysterectomy. Like, who does that when somebody's in labor? Like, that's really traumatic. Like, why should I trust you with me and my baby if you're like threatening me with things like that? So I think I would trust my instincts a little bit more, and make sure I follow through on that. But there was a lot happening mentally. I don't know. That's what I just say. I'm still unpacking it. It's 3 years later or 2 years later, and I'm still traumatized. So I honestly don't know how much different I could do than what I did.
So I would say that I wouldn't do anything differently because I wasn't at fault. So there was nothing like, well, if I would have, no. I'm not going to accept or the idea that all I had to do was no, because I'm not changing up who I am. I'm not shrinking who I am. I'm going to present how I present, and at every instance, the treatment coordinator was in the wrong. So there was nothing that I could have done differently that would have produced a different outcome. And I will say that I still go to this dental practice. So like, I think that's like another great question. Like, oh, so now did you stick it to them and say, look, this is racist practice, and this, you need to address this policy because it has racialized, outcomes, and then let me change dental offices? No, I'm not. I'm going to actually take time to teach that to the dental practice, right? And then I'm going to say, and I decided to do just that, and they have been amenable and open to hearing that. Like I said, that my dentist was like, was willing to admit that, what, I did have a role here, right? So and this is what I'm going to do, right? I'm actually going to go ahead and see you. I'm actually going to have you move forward with the procedure. You can pay as you have been doing like, so literally he's since corrected his steps, and I feel like that's important for me. And I think that similarly, that's how I often that's how I often kind of think about addressing and dismantling racism. Because if I'm quick to, and I'm not suggesting that this be the response that everyone takes, so like sometimes like in Alexis, you know, case, it's kind of like, no, I just need to go somewhere else, right? There are times where you just need to go somewhere else, but I feel like this wasn't an instance where I just need to go somewhere else because of the longstanding you know, relationship and, you know, that I've had at this particular practice with him. Yes, he had this new personnel come in and that was just like an egregious encounter, and he, you know, named that and, you know, called for it, even though yes, he also had a role in creating this policy, and he has since taken responsibility for that and have, you know, have stepped back and said, okay, you know what, let's look at this. So I appreciate that. But what I'm not going to do in this case and in some other cases is every single time I experience racism, you know, sometimes there's going to be times where this needs to be a teachable moment, and I need to, you know, and I'm willing, because I'm choosing to do it. I'm not saying everyone should take on the labor of teaching this to everyone, but in this instance, I'm willing and choosing to do it because of the fact that it takes a lot to find a, you know, whatever medical practice, whether that's a, you know, dental or your therapist or the PCP, you know, it takes a lot to like you know, find someone, establish it, have rapport and all the things. And the fact that I can even come to him and say, you know what, this is my experience, and this is how I feel about it. Like, you know, what are you going to do? Right. You know, like I feel like the way he received it was a way that was responsible. And I appreciate that and respect it. And then, you know, moving forward, I think that's one that it's almost kind of like there's an opportunity for him to grow, you know, in his practice, to grow from this. And I'm gonna, you know, I want to witness that and be a part of that. So I have chose to stay at this particular dental practice, even though that was, you know, particular instance of racism and the policy was racist. But I, you know, the dental practice, he and the dental practice have since learned from that, and I feel like they've grown.
Yeah. Can I just add to that? Like, that question is so interesting because, and I'm just gonna say, one, it assumes in some way that we may not have done things right, which there may have been things I could have done differently, but two, it takes onus off of the practitioners, which I don't think is right. Because sometimes they're the ones who need to change. Like that OB, her entire staff was white, right? And could I have found another OB that was Black? It would have taken me months. I spent 3 months just trying to find her, right? So how much could I actually do differently when the system and structure in place doesn't allow me to do that? So I think that's something that has to be acknowledged. There's a point, right? Like we can only go so far, and then at some point that other side has to pick up the rope and continue the work. We can't do it all for you. And just as you said, Miranda, you know, some moments are teachable. I've gotten to the point in my advocacy where there's sometimes where I'm not teaching, I'm done. Like sometimes I respond, sometimes I react. And this was a moment where I responded with, I need to handle my own care and my own mental health, because it was very traumatizing. Like I literally thought for months after having my baby that I was going to die. Like every day I would wake up like, oh my gosh, I need to pump extra milk because I'm going to die today because I'm going to have a blood clot or something like that, because she told me that I stressed myself or whatever it may be, right? Or she told me I was uncooperative and that caused me to have all these other things. Like there was months of that happening to me. There's no way I could even think about how to change any of my actions when my basic human instinct isn't even intact, like keep myself safe and alive, right? Like that's what I'm dealing with. So sometimes we have to really take a step back and think, who was really at fault here? Was it both the individual doctor and the patient? Is it the structure at play, or is it all three? And then how can we create change or create policies and practices that work together so all three parties can move forward in a way that's going to be healthy and helpful for the patients, right? So
I think that's a really important point, that the burden shouldn't be on you to change, and also makes me think of quotes I've heard that structural problems require structural solutions. So the onus shouldn't be on individuals to try to change these structural issues, which gets at a comment in a question and a comment from the audience. So it says, I'm a practicing Black anesthesiologist who worked in a mostly Black serving hospital. I've seen a lot of white supremacist behavior from non-white and white healthcare workforce. What are solutions? Interpersonally, I try to challenge people, but it's a limited approach, obviously. And I think it also gets at sort of the burden placed on the individual to do that. So, what would you all say to that?
I mean, that's like a really big question. It's like the question is like, how do we end white supremacy? It's like it's like what? Like it's just there's so much to address with like, where do we begin? Which is why it feels daunting actually to, address colonialism and, all that comes with, racism. Well, because it's like at the root of racism is white supremacy. So, but the thing is that it takes a multi-pronged approach just because racism and white supremacy exist in so many you know systems and like so many levels. So yes, oftentimes like, because I'm an educator, so oftentimes it's kind of like, oh, let's talk about the interpersonal and the microaggressions and the bias at the individual level, right? But we know it's so much more than that, right? Yes, we have to think about the ways in which we engage and interact with each other, and we have to think about the ways that those narratives and those values and those ideologies get baked into clinical algorithms and hiring practices, and like literally at every step we see how racism kind of shows up, and like I said, and at the root of that is white supremacy. So there's just so many levels, which means that it's going to take some policy change. It's going to take changing workplace culture, right? It's going to take addressing the one-on-one kind of interpersonal interactions, and it's like both and all happening simultaneously at the same time because they're all mutually reinforcing, which is why this is lifelong work. And again, to the point that we've already raised, I realize that not everyone is interested in doing this work. Right, but I will say, here I am in an academic institution, and our dean was our first woman dean in the School of Medicine and Health Sciences. It was our medical enterprise, made the bold statement that we're going to be an anti-racist institution. Now, it's like, I think it would be disingenuous of us if we didn't name the legacy of racism and, even within our institution. So like, I feel like oftentimes we have to start really turning the mirror on our own institutions and departments and programs and the ways that we have brought about harm and the racist practices that we have turned a blind eye to, and actually do some of that first, because we don't want to bring harm to the very people that we're bringing into our doors, into our programs, whether we're talking about patients or we're talking about students or faculty or program administrators. So it really is, there are multiple factors at once.
Yeah, and I'll add like that is such a big question. And I'm a trained sociologist, so I look at, social structures, practices, things like that, policies, inequality historically over time and how they relate to the situations we're in today. And I would say, that question really speaks to going back to what are we teaching our practitioners, right? What's the curriculum they're learning? Are they within those courses being not necessarily being taught, but actually utilizing Black and Brown scholars, within the literature that they're seeing in their classroom? Are they situating themselves in communities that are facing these challenges every day for their training, right? Are they, as young scholars and medical students, learning to dismantle those systems as they go through the program? Because that makes a difference. You're either going to train them in the system that already exists and is already broken, or you're going to break that system down from the beginning and change it with the knowledge that you're putting out and producing over time with your next generation of practitioners. And I think that's the key, is like, when you take that internal look, not only at your department, but across the field as a whole, how many of those people who are teaching in those institutions, who are teaching future doctors, who are teaching future nursing students, actually, sit in community informed practices, right? Have been in those communities, have spent time in those communities. How many of those programs are pulling people up and saying, hey, they've experienced this, let's learn from them and meet them at the table, and bringing them to the table to develop the curriculum in the first place that's being taught? So I think it stems a little deeper. There's the structural component, right? Like, we talk about structures in this big way, but really it comes down to who's producing the knowledge, where does that knowledge come from, and what knowledge are we continuing to share for generations? And how do we break that down and share knowledge that's more genuine about our communities and more authentic in terms of what people are going to face on the ground. How do you approach these communities and these individuals and groups?
Thank you. Another question, how do we hold healthcare professionals and organizations accountable outside of just like a malpractice suit?
I think that through policy and practice. So, for example, there are some times where patients will come in and they'll see a Black doctor or, a Southeast Asian doctor that has an accent, and they'll say, "Oh, I don't want to be treated by that doctor," right? And the organization could do one of two things. They could say, "Oh, let's go find you another doctor," which would then actually be reifying this idea that, patients like that, practitioners of color don't have what it takes to actually serve them, and that they're well in their right to actually, request a white doctor. Or they can say, you know what, that's not tolerated here, right? All of our clinicians are well trained, and if you choose not to see this doctor, you're refusing care. So that's an example of how you can take a policy, you can make it the policy that no, we will not have patients coming in and requesting certain doctors, and then on the flip, you can talk about on the clinician side what they will or will not do with certain patients. That becomes a policy, and then that becomes a practice where you hold that, like those in senior leadership positions hold that, and that becomes the practice, and that it just becomes a zero tolerance. Like, we will not tolerate that, right? Here everyone is respected, and you make it clear that what we pride ourselves on having diversity and what that looks like, that you're not going to pick and choose and suggest that someone is substandard based on the way they talk and the way they look. And so that just is like, that's one of those examples, and I feel like from the kind of clinician side.
Listen, I'm not in the medical field, so I don't know what you all have on the background in terms of like ethics and things like that. But as an outsider, I would say that that's something that needs to be revisited. If you know that you have doctors and practitioners that are out there explicitly, and sometimes even, unexplicitly creating harm in terms of like racialized harm and trauma and things like that, why can't your medical boards hold them accountable for that? Why can't they withdraw licenses? I don't understand that as an outsider. Malpractice suits is one thing, but taking away their livelihood is a whole nother. That'll change how you interact with people in a heartbeat, right? Like, you can't do the thing you love for your career or whatever it may be, because you don't know how to treat people with respect, like they're human beings, right? Like they have a voice, like they're valued. Like, that to me is a big thing. So maybe as a discipline, as a field, that needs to be revisited. How are you actually following through with your ethics and standards for doctors? And how can that be more well made known to patients so they know that they can pursue that avenue? Because right now it's like individual patients against giant hospitals or giant networks. And we know that when people aren't collectively organized and collectively working together, their voices tend to go unheard. So I think that's something that needs to be revisited and looked at outside of, suing, because that's what we do as a culture. We sue, but there's other ways to pursue it, right?
Yeah, I think of, organizational change definitely takes, time, but I think that really when people tap into and weaponize their privilege, right? So if you know that you have privilege associated with your social identities, you're a white man, or associated with your credentials, like, oh, I'm an attending, or, when you actually tap into the power and privilege that you have, and you can be the one to actually bring about that change and say what's acceptable here. So for example, like Health Affairs, actually not too long ago, they issued one of the issues had an article on how Black and brown patients were more likely to actually have in their patient, like in the electronic health records, be written up and described as difficult or non-compliant, right? These kind of like coded language. And so that literally, before the clinician even opens the exam room, they look at the the EHR, right? And so like it's already colored their perspective on who they're actually even going to encounter. And that very well they may decide, well, here they go, somebody who's difficult. So I'm not even gonna give a full explanation because you anticipate that they're gonna be difficult. So now you're already going in, not giving them the full information so they can make informed, decisions. So that's an example of how bias kind of gets, codified in like processes. And so that's where people that have power and influence can say, you know what, this is unacceptable. Like, you know what, don't use like coded language in this way, like make very clear, like use, like focus on the actual medical facts, right? And don't use shortcuts, those type of things. I feel like there's just ways for us to change organizational culture.
And I think that's a great point. I was labeled as uncooperative for refusing to have a C-section, for refusing to lay in the bed instead of walk and be mobile, for refusing to get off the toilet when I needed to pee. I was uncooperative. Also for refusing to continue to be on Pitocin when my labor was not progressing and asking for them to pause me so that I could rest. I was labeled uncooperative. And the biggest fear for me in that was this whole experience of what was happening in social media at the time, medical kidnapping. I was like, after I have this baby, when I go into this other ward and the social worker comes in and they open up my file and they see I'm uncooperative, what are they going to do? How are they going to judge me? Are they going to take my baby? And because of that, I was like, I have to get out of this hospital quick. I have to do whatever is possible to get out in less than 24 hours because I did not want that to happen. And I think you're absolutely right about that. It manifests in those ways that I don't think that sometimes doctors even realize, or maybe they do and they just don't care. I don't know.
Well, thank you to you both. I wish we had more time for questions, and I encourage everyone to read the full essays on our website, healthaffairs.org. So thank you again, Miranda and Alexis, for telling your stories, for being so vulnerable, for finding sort of, hoping for solutions and discussing kind of a future way forward, and for taking our questions today. This was the last of the events this month that were offshoots of our October theme issue, Tackling Structural Racism in Health. I encourage everyone to visit healthaffairs.org to read the issue and engage with all the products that are aligned with the issue, including events, videos, poetry, and much more. We will be back in November with more events. So thank you again. Thanks to our audience. We are adjourned.
Thank you. Bye.
Thank you. Appreciate the opportunity.